Advanced vascular medicine will now consider in greater detail deep venous thrombosis with an eye towards the potentially fatal complication of pulmonary embolism. Deep venous thrombosis is exceedingly common, particularly in hospitalized patients, and is a great cause of rehospitalization, morbidity, and as I said, even mortality. So we're going to look at deep venous thrombosis in much more detail compared to previous. First of all, let's review some of the definition. Deep venous thrombosis is a thrombus, a blood clot, within a deep vein, not a superficial vein that you can see on the surface, but a deep vein. It's associated with breaking off of the clot and embolizing of the clot into the lung, and blockage of the main artery of the lung or one of its branches by an embolus may cause severe symptoms, may cause decrease in blood pressure, and can even be fatal. DVT and pulmonary embolism are often lumped together using the term venous thromboembolism. And you can see in that term, we're including both the clot in the vein and the embolism to the lung. The obstruction in the vein is caused by the thrombus that breaks free and is carried away with the blood flow up to the lung. Now, one of the great problems in clinical medicine is that most DVT and pulmonary embolism is silent. You can see here in this pyramid, which you've seen before, that the overwhelming majority of patients with DVT and PE have no symptoms. So that's one of the reasons why it's important to be looking for it with non-invasive tests that we'll mention later, for example, ultrasound. A small percentage of patients, the DVT and pulmonary embolism become symptomatic, and fortunately a very small number, but somewhere around 6% of patients with pulmonary embolism die from the pulmonary embolism. It's often in the setting of severe illnesses of another type, such as cancer and heart failure and so forth, and where the final blow that kills the patient is a fatal pulmonary embolus. Let's talk about the epidemiology of deep venous thrombosis and its relationship to pulmonary embolism. I've already implied that this is a very, very common entity. You can see here that in the United States, 1 in 1,000 individuals per year is diagnosed with DVT. You can do the mathematics. In a country of 330 million people, we're talking about many, many tens of thousands of episodes of deep venous thrombosis. When the venous thrombosis is in the popliteal veins, a small vein down in the lower part of the leg, usually it will stay there or resolve by itself without major pulmonary embolism. Unfortunately, about 10% of these patients will develop proximal DVT, that is the DVT that extends up into the femoral vein, and 10% of proximal vein DVTs lead to pulmonary embolism. So many patients with DVT don't develop pulmonary embolism, but as we've said, when they do develop pulmonary embolism, it's potentially fatal. 50% of untreated proximal DVTs lead to pulmonary embolism within 90 days or 3 months. And greater than 90% of pulmonary embolisms are due to lower leg DVTs. Occasionally, there's clots in the pelvic veins from an infection or post-pregnancy, and clots can break off there and embolize, but that's only 10%. 90% of the DVT is in the veins of the legs. What are the causes of DVT? Well, probably the most famous pathologist in the 19th century was Rudolf Virchow here in Germany. Virchow noted that 3 conditions were needed in order for blood clots to form inside a blood vessel, particularly the vein. First of all, there had to be decreased flow, stasis, and such as happens, for example, from standing long time, the blood tends to pool in the legs. The second is hypercoagulability. That is, the blood has to have a tendency to clot that's above normal. And finally, there needs to be an injury to the endothelium, to the inner lining of the vein, so that a blood clot can start to form there and propagate and get larger, and eventually, of course, in a significant percentage of people, break off and embolize to the lung. So circulatory stasis is alterations in normal blood flow with decreased flow, with a tendency of the blood flow to stay in one place. Endothelial injury or dysfunction, that can be due to trauma. It can be due to surgery with vessel piercings or damage. And of course, it can also be due to toxic substances, for example, things contained in cigarette smoke. Finally, hypercoagulability is an increase in the constitution of the blood so that it increases its propensity to clot. This is seen, for example, very, very strongly in patients with cancer. When patients have cancer, the coagulation system is markedly activated. Here are a number of different kinds of ways that you can have hypercoagulability. Many of these are inherited. Cancer, of course, is not an inherited one, but there are a number of inherited ones. First of all, there can be the lack of a naturally occurring inhibitor of blood clotting, protein C or protein S. These prevent us from having constant clotting going on in our blood system all the time. If you're born with a decreased amount of protein C or protein S, you will have an increased tendency to clot. There are also naturally occurring abnormal coagulation factors. One of the most famous one is called factor V Leiden, discovered by medical scientists in Leiden, Netherlands. Or there is an abnormal prothrombin. Each of these are factors in the clotting cascade, which is a whole series of chemical reactions that leads to a blood clot. And if one of or more of them are abnormal, it markedly increases the tendency of spontaneous clotting. The frequency of recurring DVT and pulmonary embolism increases by a factor of 2 in patients with inherited hypercoagulability states. Say it another way, if you have one of these abnormalities in the clotting system, you will have 2 chances in 100 of developing recurring DVT-PE, which is much higher than the 1 in 1,000 in the natural population. But most patients with these abnormalities never experience an intravascular thrombotic event, so it doesn't make sense to try and find out everybody in the society and treat them with blood thinners, because you'd have many more hemorrhages than you'd prevent DVT. So what we do is when a patient develops DVT or pulmonary embolism, we check for a factor, because if they do have that factor, we know they have an increased risk of having the DVT pulmonary embolism repeat, and consequently those patients go on blood thinners for life. But most patients with these abnormalities will not have a problem. Other risk factors for DVT, I already mentioned cancer, but one can have recent trauma that injures the vein and therefore satisfies Virchow's number 1 requirement for DVT, which is injury to the endothelium. Recent surgery, the same. Immobility results in stasis. Cancer, marked hypercoagulability. Estrogen, either in pregnancy or birth control pills, increases coagulability. And of course, as we've already mentioned, prior DVT or pulmonary embolism increases the risk for having it occur again. Again, just to reiterate, here are some of the inherited hypercoagulable states: protein C or protein S deficiency, factor V Leiden or antithrombin 3 deficiency. There can be, particularly in patients with systemic lupus erythematosus, a clotting antibody that increases the risk for blood clots forming. Some patients are born with a very high level of an amino acid, homocysteine, that increases the tendency for clotting. And again, some patients with lupus will actually have a protein that activates the clotting system different from the antiphospholipid antibody. Some patients will have elevated antiphospholipid antibodies without having lupus. Hormonal therapy, it's important to stress this. Hormonal therapy, either given as contraceptive pills or pregnancy where there's high levels of female hormones, increase the coagulability of the blood and therefore increase the risk for DVT and pulmonary embolism. So pregnancy or pseudo-pregnancy, which is induced by the oral contraceptive pills, or postmenopausal hormone replacement all increase production of clotting factors in the liver. This leads to a hypercoagulable state, in other words, an increased propensity of the blood to clot. The increased risk for intravascular disease events, myocardial infarction, stroke, DVT, pulmonary embolism, all occur with these products and with these states because the blood is at a higher likelihood of clotting. And by the way, if you add cigarette smoking on top of one of these things, for example, birth control pills, you markedly further increase the risk for developing DVT and PE, which is one of the reasons we strongly recommend that women who are taking birth control pills not smoke. A little bit about the pathogenesis. You've seen this slide before. As you heard, 90% of DVTs and pulmonary emboli occur in the veins of the leg. Often they start as very small clots in the popliteal vein, and often they will dissolve and heal without any problem. But once they get up into the femoral vein, which is a lot of people, you see 42% of people, there is a greater likelihood of the clot growing. And then you can see once it gets up into the common femoral vein or the iliac vein, inferior vena cava, there's a very significant chance that a large mass of clot will embolize to the lung and might prove to make the patient either very sick or even die. Just to emphasize one more time, the consequences of venous thromboembolism, pulmonary embolism can be fatal. It can cause a very serious illness, acute morbidity. Once you've had one, you're at high risk for more. Thrombophlebitis itself, as you know, can lead to the post-thrombotic syndrome with edema and ulcers, and in a rare case, even amputation. So thrombophlebitis is defined as the presence of a thrombus in the vein. It's accompanied by inflammation in the vessel wall. It can happen, of course, in superficial or deep veins. The dangerous one is when it occurs in deep veins, not in the superficial veins. Of course, the danger is pulmonary embolism, and we've already talked about all the things that can lead to deep venous thrombosis, including long periods of sitting or standing or a long plane trip. We've also already mentioned the post-thrombotic syndrome. This is a long-term complication of DVT and venous insufficiency where the internal veins are not working well, the valves are not working, blood pools, the vein dilates, there's a great tendency for blood clot to form, edema forms, there's poor skin nutrition, and often ulcers develop. Blood proteins and other blood products, hemoglobin, are deposited in the tissues, giving a brown discoloration, and the ulcers can be exceedingly difficult to heal, taking many months to heal with constant therapy. Again, just to reiterate for how common DVT is, patients in the United States in 1 year will have clinically evident venous thromboembolism, a total of 900,000 patients. And the deaths there are about, that are due to pulmonary embolism, are about 300,000. And the annual incidence of venous thromboembolism increases by age and sex, as you can see in the graph, particularly as patients get above age of 55 to 65, there's a marked increase in venous thromboembolism. Males a little more than females, but not a very, very much difference. Again, a huge increase. This data comes from the Worcester Vein Study in Worcester, Massachusetts. The University of Massachusetts Medical Center has been studying all cases of DVT-PE in Worcester County over many years. The symptoms, I think we've already talked about these. The symptoms from deep venous thrombosis and pulmonary embolism may be none. The patients may be asymptomatic in at least 50%. The inflammatory process in the leg may lead to some discomfort. There may also, of course, be some edema. There may be tenderness when you touch the thigh or the calf. When there's pulmonary embolism, the patients complain of shortness of breath. Heart rate and blood pressure may be abnormal with a fast heart rate and a low blood pressure. And sometimes the clot in the lung results in damage to the lung itself. And when that happens, you have a pulmonary infarct, like a myocardial infarct. It's actually some death of pulmonary tissue, and that results in pain that is pleuritic. That is, it occurs or gets much worse when you take a deep breath. When the patient has a chest pain that they say, oh, I can't take a deep breath because it's going to hurt, that's pleuritic chest pain, and it's due to irritation of the lung and the lining around the lung. The diagnosis, again, physical exam sometimes helps, although very often the physical exam is unremarkable. But you may see unilateral, one leg or one ankle has edema. You may have tenderness when you palpate or touch the calf. There may be some redness in the area or warmth. Rarely you can actually feel a cord from the thrombosed vein. Holman's sign, which is also rare, is when you bend the foot up, and that stretches the gastrocnemius muscle, stretches the vein, and it hurts. But it's very rare, and it's not very sensitive or specific, and we really don't do it much anymore. I only put it in here because you may hear about it in your teaching. It's not a very useful physical finding. Unfortunately, the majority of patients with DVT are asymptomatic, and there's nothing on the physical exam that shows you that it's there. So you need instrument-based techniques. One of the clues, by the way, that the patient may be having pulmonary embolism is, we talked about before, elevated heart rate, increased respiratory rate, normal or lowish blood pressure, and when one checks the carbon dioxide and the oxygen in the blood, they're both low. But these are, again, fairly nonspecific findings that can occur with pneumonia and heart failure. So what are the tests that define and show us that there's DVT? Well, you can actually do an angiogram of the vein called a venogram, in which you squirt some dye in the vein and you see areas where the dye is not going because there's blood clot there. It's not really used all that often because we have many excellent non-invasive tests. And it's time-consuming, uses dye, and has radiation exposure. Ultrasound is the way these days that most cases of DVT are diagnosed. It's low cost, it's portable, it's non-invasive, and you can see with an ultrasound the vein can't be compressed because there's clot in it. You can sometimes actually see clot in the vein, and with a Doppler you can see that there's decreased flow in the vein. There's a blood test, which is a breakdown product of a clot in the vascular system called D-dimer. And when that's elevated, it suggests that there's clotting going on intravascularly. There's a test that measures the volume change within the leg called plethysmography. This test was more popular in the past, but not so much now. And of course, CT and MRI can also show this. So let's talk a little bit more about the ultrasound test. It has two components. First of all, there's a color flow Doppler that shows us when flow in the vein is abnormal. It takes about 45 minutes to do that. Another test that we do with that is we look at the vein, we look for clot in the vein channel, and then you try and squeeze the calf and see whether the vein collapses. It should collapse when you squeeze the calf. If the vein doesn't collapse, it usually means that there's a clot in there because a normal vein should collapse nicely. It is of interest that clots that are in the popliteal vein or below usually don't embolize, and they're usually very small. But they can propagate, they can increase in size, and so if you see some clot in the popliteal vein, you need to redo the ultrasound scan again 3 to 5 days later because the clot may have increased in size, thus making it much higher risk for pulmonary embolism. And again, as I mentioned, the clot's identified by failure of the vein to collapse when you squeeze it. The duplex ultrasound and the limited compression are really very good tests for diagnosing DVT. And These figures are not easily seen, but on the one on the left, actually there is a clot in the vein, and the one on the right, there is failure of the vein to collapse when the calf is squeezed. There are a number of little tricks of the trade. A good technician, a good ultrasound, a deep venous thrombosis technician can, as I said, see augmentation of flow when they compress the calf, and also they look to see if there's collapse of the vein when they squeeze it. You can adjust the gain, that is how bright the image is, so you get a better view of the vascular system. And again, if there's plus minus findings, you can do the other side to see if it looks normal compared to the side that you're thinking has DVT. So there are a number of little tricks that a very good ultrasound technician is very accurate in finding deep venous thrombosis with its potential for thromboembolism. Of course, when there's intravascular coagulation or blood clotting, the treatment is going to be intravenous and or subcutaneous injection of an anticoagulant. For example, heparin, or an oral agent, warfarin, or one of the new agents, dabigatran, rivaroxaban, apixaban, or edoxaban. All of these have been approved and are very effective for treating DVT and pulmonary embolism. What they do is they prevent the clot from propagating, and then the body's own enzymes break up the clot slowly over time. One can give heparin that's unfractionated, a big molecule that's associated with a little more complications than the newer form of heparin, which is only part of the heparin molecule, which causes the anticoagulant effect. The major side effect is bleeding. When you thin the blood, there's always a risk for bleeding internally or externally. One can do surgery or catheter removal of the clots, or one can actually put a filter in the vena cava to prevent the clot from coming up. This is only done in critically ill or high-risk patients. And finally, where there's a huge amount of clot, we can give thrombolytic drugs that are known as clot busters. They dissolve the clot. They're actually chemicals that are based on the body's own thrombolytic enzymes, but in much higher concentration, and therefore very effective at dissolving the clots. Chronic therapy, if the patient has one of these hypercoagulable inherited factors, it may be that they need anticoagulants for the rest of their life, but in general, usually 6 months to a year of anticoagulant therapy and then stopping and seeing what happens. I've already mentioned that there's warfarin. Warfarin is a thinner that requires frequent blood tests to make sure that the level is adequate or not excessive. But the new oral anticoagulants, dabigatran, rivaroxaban, apixaban, and edoxaban, do not require blood tests. They don't require special dietary restrictions as with warfarin, and they are very, very popular. Again, because they're new, they're more expensive. In the United States, most insurance companies cover these new agents with only a modest additional copay. And many patients are choosing this instead of warfarin, the older therapy. And of course, exercise. Frequent walking, the muscle pump helps to milk the veins and prevent stasis. Compressive stockings, we've talked about that again, help prevent venous stasis. By the way, we talked about the fact that when you've had one episode, you're markedly likely to have another episode. Here you see from a study that followed patients who had a first episode of DVT with pulmonary embolism for 8 years, and you can see what happened. In the first year, there was already 5% had a recurrence, the second year 10%, and already by the 8th year, almost 30% of the patients had had a recurrence. So this is a major risk factor for further DVT PE when you've had one episode. In terms of prevention, of course, we want to try and prevent injury to the vein. We want to try and prevent hypercoagulability, and we want to try and prevent stasis. Some patients who are high risk will have anticoagulants after delivering a baby, postpartum, and early ambulation after surgery. Anti-embolism stockings, we've talked about that, the compressive stockings. Some patients use pneumatic compressive devices when they're in the hospital to keep squeezing the calves, to keep squeezing the blood out. We can elevate the leg to cause better venous emptying every hour or so. Permanent elevation of the leg also helps to prevent stasis. And then after surgery or any injury, the sooner one gets the patient to ambulate and get the muscle pump working on the veins again, the better. In summary then, I think with the deep venous thrombosis and pulmonary embolism lectures we've talked about, I think it's clear DVT is exceedingly common. It's often missed because there's no findings that point to it, and it is potentially lethal. The diagnosis is therefore often difficult, usually requires sophisticated non-invasive tests such as ultrasonography. The physical exam can make the diagnosis at times, but not always, and effective therapy can definitely save lives.